Okay, here's lesson B for EMS 270. We're going to talk about bites and stings, all types of things that bite and sting, and then anaphylaxis from various causes. And then we're going to introduce angioedema, talk about the differences and similarities between anaphylaxis and angioedema. Bites and stings, whether it's a scorpion, whether it's a bee, whether it's a wasp, whether it's whatever it is, the venom is the issue with any bites. Sometimes the bite or sting reaction is only local to the site. The venom is contained locally, does not become a systemic problem. Other times becomes a systemic problem. Now, while there's brown recluse bites and all kinds of other bites and stings and things to worry about, from a field perspective, our focus is on whether or not the venom is causing an anaphylactic reaction. All venoms have the potential for anaphylaxis. Not all are going to create that sort of a problem. So basically, it's a local soft tissue problem that may also include a systemic anaphylactic problem. So in general, whatever animal has stung or bitten, if there's a stinger or tentacle still involved, get those out, scrape those out. Don't use tweezers to squeeze them out. The venom sacs may still be attached and additional venom may still be injected. So scrape it out. Use a card of some kind, badge buddies work, driver's license, credit cards, whatever, name tags. Try to scrape the stinger or scrape the tentacles off, and then just do standard wound care. Keep it clean, keep it dry. Ice is a good thing, heat is not. Tourniquets are not a good idea for this. And this has changed over the years several times back and forth. The current recommendation is keep it clean and dry, cool it if you can. Don't try to restrict the flow of the venom. No tourniquets. And then if it's a jellyfish specific issue, after you've done all those other things, vinegar is a specific antidote to the jellyfish venom and can be used in the local area. And then, of course, a good shower after that. So there's just not a lot to this. It's very BLS-like in terms of dealing with the local wound. Then you need to worry about, is there an anaphylaxis? Now, anaphylaxis can come from any of a number of things: seafood, medications, peanuts, all kinds of things, as well as venom from a bite or a sting. Anaphylaxis kills through upper airway swelling, through lower airway obstruction, and through distributive shock. Not all of these are going to be present every time, but upper airway swelling is where we're going to start. So how do you know if someone has upper airway swelling? Well, they may have difficulty swallowing. They may be drooling a bit because they can't swallow normally. And then if you will listen over their larynx, externally over the Adam's apple, if you will listen, you may hear stridor. Stridor would be a high-pitched squeaking sound. It can be on inspiration or expiration, more often on inspiration. And differentiate that from wheezing. Wheezing in the lower airways will also be high-pitched and musical, but it's location, location, location. Wherever you hear it loudest is where it is. So when you're auscultating for stridor, you should also auscultate for wheezing and do your best to differentiate the two. They may both be present. And so stridor is something that we take very seriously, indicates significant upper airway swelling, potentially a pending upper airway obstruction. And racemic epi seems to work well for that. Racemic epi is more or less a topical application of a vasoconstrictor, which helps to shrink the tissue that's swelling in a kind of a similar way to when you use a nose spray. When you have a stuffy nose, use a nose spray, and that has an epinephrine equivalent in it. And when that's applied topically, it causes vasoconstriction, which allows for the swollen tissue to shrink down. So upper airway, stridor, racemic epi is a good plan. Lower airway, wheezing. And albuterol, ipratropium, the standard bronchodilators are an obvious plan there. So you want to do a respiratory assessment on your anaphylaxis patients. Then you also need to do a cardiovascular assessment on your anaphylaxis patients and look for distributive shock. Look for an inappropriate vasodilation, an inappropriately large vascular container that comes secondary to the massive histamine release that goes along with anaphylaxis. Epinephrine breaks that reaction chain. There's multiple steps in it, not important for us to know. What is important for us to know is that epi breaks the chain. Yes, epi also does some bronchodilation, which may help with the wheezing. And yes, epi also will do some vasoconstriction, which can help with the shock. But the reason we're using epi in anaphylaxis is to break the reaction chain, put out the fire, stop the massive histamine release. Benadryl and other antihistamines simply try to soak up the histamine that's been released, but it doesn't stop the release of the histamine. So we would like to think of this in terms of a fire. If you have a fire, you want to go in and put out the fire and then blow the smoke out of the house. So epi puts out the fire. Benadryl simply blows the smoke out of the house, yet the fire continues. So use epi to put out the fire to break that reaction chain. Now, the epi we're talking about here is epi-IM. Sub-Q is how we used to give it. Now it's IM. It can also be IV for very severe anaphylaxis. And this is different than the racemic epi. But by giving someone with anaphylaxis and stridorous, giving them racemic epi doesn't break the reaction chain. That's not what we're talking about. That racemic epi is for a specific purpose of shrinking that swollen upper airway tissue, whereas the IM epi breaks that reaction chain. When in doubt, we think it's appropriate to go ahead with epi. Probably use some caution in that person that looks like they're teetering on the brink of an MI at all times, somebody with severe cardiovascular issues to start with. They may not do well with that epi, but it's a judgment call. If the anaphylaxis is going to create a problem for them, for sure, then giving epi would seem to make sense, even if there's a risk of a possible problem in terms of creating an MI or something like that. So most standing orders will direct you to go to epi pretty quickly, and then when in doubt, you can always make a phone call and get direct online medical control. Remember, your protocols have standing orders that allow you to do things when appropriate without calling for permission. They don't compel you to do anything without calling. They don't preclude you from calling. So if you want to call online medical control and say, here's what I've got, this doesn't really fit the usual protocol and standing orders, and so there's nothing wrong with that. Actually, that's good medicine. And so sometimes you have a judgment call here on, do you give the epi? Maybe your patient's already taken some Benadryl and they're having some mild symptoms, but you're concerned, they have some swelling in their lips and such. And so there are some judgment calls here, and judgment calls are best handled on the phone with medical control. So there's anaphylaxis and there's angioedema. They can be occurring together or they can be occurring separately. Angioedema is not technically an anaphylactic reaction. It's called anaphylactoid. It's like anaphylaxis, but it's not an allergic response necessarily. It involves, and I'll show you a couple of pictures here in a minute. You can Google for some completely frightening pictures if you'd like. But angioedema can be very, very dramatic in terms of swelling of the lips and face and tongue, and that's what you can see externally. And then you're going to have internal upper airway swelling as well, which can become life-threatening. So if you have a patient with stridor and you have a patient who has some swelling of their lips and tongue, that seems to be an anaphylactic enough response that it does have angioedema component with it, but you're still going to want to deal with that with epi. The good thing about angioedema, if it's not involved with anaphylaxis, is that it's self-limiting. It resolves without treatment. It's dramatic. It's scary, but it's usually not a big deal. Could become a big deal, but frequently will resolve without treatment. But in the case where you think there's an anaphylactic reaction going on, if they have hives, a rash, have blood pressure issues, that's anaphylaxis along with angioedema, and epi is what you want to go with. Here's some pictures. On the right, the patient before the angioedema attack, and on the left is a pretty dramatic, although not all that rare of a presentation. Pretty marked swelling of the lips and face, and then internally you would expect to see a similar amount of thing. So when we're treating a patient with epinephrine for their anaphylaxis, We would also want to know if they're taking beta blockers, because beta blockers will block the epinephrine, at least the beta side of the epinephrine, and not the alpha side, and so this is not a good thing. So it would be very helpful, if at all possible, to determine if your patient is taking a beta blocker. Remember, beta blockers are given as a prophylaxis for heart attack and stroke. They basically govern the engine, so to speak. They keep the heart rate from increasing. Beta blockers are medications whose generic name ends in OLOL. So metoprolol, atenolol, propanolol, other labetalol, medicines that end in OLOL. Interestingly, glucagon, which we tend to use mostly for raising blood sugar, glucagon also has some other effects, and one of them is it will reverse that beta blockade. So when your patient's taking beta blockers, you should go ahead and intervene with the epinephrine, and then you may need to consider the glucagon. And again, this would be a great time to be on the phone with some online direction, because this can be complicated and is certainly not the norm. Here's our general flowchart protocol sort of thing for patients that have anaphylaxis or angioedema-like symptoms. Check on that stridor first. If they do have stridor, you need to get moving. You're going to need to get moving, because it may be that they're headed for an airway obstruction. Get them going, get some epi involved, and then set up for one of the more difficult airways you will ever manage. Once you've got that working, then start figuring out if they're in shock. Do they have signs and symptoms of shock? And remember that signs and symptoms of shock are independent of blood pressure. Blood pressure tells you whether it is compensated or decompensated shock, but you don't need a blood pressure to decide if your patient is shocky. Again, those that are having shock symptoms need epi and transport, and those two things pretty much need to start happening at the same time. Epinephrine IM is quick and easy to give. Patients carry their own EpiPens to give themselves an IM injection. You need to get moving. Sometimes you will need to deal with shock by also giving fluids, but your first line of treatment is that epi, and then make an attempt to get some vascular access, and you may need to give some fluids to fill up that inappropriately large container. Yes, the epi will likely get you some vasoconstrictive effects, but in some cases you may need to add some fluids on top of that. So once you've got that going on, then also determine if your patient's wheezy. If they are, standard breathing treatment is not a problem. Go ahead and use that. Again, the epi is a beta-2 agonist, so epi is going to open up constricted bronchioles and give you some of the same effect, a pretty strong effect. But again, we're using the epi to break the reaction chain. The fact that it may also treat some of the symptoms of the reaction is just icing on the cake, but we're really using it to break that chain. So what's the role of Benadryl? Well, Benadryl, you should even be thinking about Benadryl or steroids until you're this far down the flow chart. There's nothing wrong with Benadryl. It just isn't going to break the chain of the reaction. It's going to help treat some of the symptoms. Steroids are a good thing with anaphylaxis. The steroid onset of action is probably an hour or more, and so it doesn't make any sense to piddle around on the scene trying to get an IV so you can give some steroids that aren't going to kick in for quite a while anyway. So if you do have IV access and steroids are in your protocol to give for this, totally makes sense. And we put consult medical control and reassess there at the bottom, but we don't want you to think that you can't call anytime. Call early when you have something out of the norm, something that you're not comfortable with, and let that physician assist you in managing it. So when we do Lab B, we'll run some cases, and so let's talk about that. Our main points, again, are that bites and stings are typically painful and kind of scary and kind of dramatic, but usually not a big deal. At least not a big deal in the field setting, unless the venom causes an anaphylaxis. Scrape the stingers off, use ice, avoid tourniquets, good general wound care. Decide if your patient's in anaphylactic shock. If you have anaphylaxis, use epi to break the chain reaction. Treat the symptoms. I've said that 4 or 5 times, so here's another 2 or 3 more times. And then angioedema is very dramatic. It's almost impossible to miss, but it's usually not a big deal unless it's also with anaphylaxis. How do you deal with it? If there's anaphylaxis, deal with that. If not, comforting measures, maybe prep for some airway stuff. Potentially it could get much worse in a hurry, but unless there's a severe anaphylactic reaction also, these are usually self-limiting. The big deal with either of these is airway obstruction. It may be that you're the only person who has a shot at intubating this patient, that as time passes, the swelling increases, the obstruction becomes total, and then you're into can intubate, can oxygenate, cricothyrotomy sort of thing. Going to run a couple scenarios. The first one is a 16-year-old female, has a known allergy, comes in contact with her known allergen for whatever reason, and we'll make up the details, but that's the general background. She knows she's allergic, and she comes in contact with what she's allergic to. She has hives, she's itching, she's a little wheezy, she has some trouble swallowing, her throat gets tight, she gets weak and dizzy, probably begins to hyperventilate a little bit, which exacerbates all of this. She has an EpiPen, but not with her. Doesn't take any other meds, so really a very simple, easy batting practice fastball, kind of right down the middle, easy scenario. What does she need? She needs Epi from you. You don't have an EpiPen, you have Epi in a vial, and you draw it up, and you give an Epi-IM injection, and things start to get better because you're breaking the chain with the Epi. Another scenario we'll run is a 66-year-old female, sudden severe swelling of her lips and tongue. She's got no hives, no itching, no wheezing, no trouble swallowing, no throat tightness. She's anxious because this is scary, but she's not showing signs of an anaphylactic reaction. She's showing signs of angioedema. She has no known allergies, but she takes lisinopril, hydrochlorothiazide, and aspirin. The lisinopril and the hydrochlorothiazide are for her blood pressure. Hydrochlorothiazide is a diuretic, really has nothing to do with this scenario. The aspirin prevents clots from forming, really has nothing to do with this scenario. The lisinopril she takes for her blood pressure, and it's an ACE inhibitor, an angiotensin converting enzyme inhibitor. ACE inhibitors are notorious for being linked to angioedema. Now, I didn't just say that a lot of people taking ACE inhibitors have angioedema. I'm saying the opposite. I'm saying that a lot of people with angioedema these days are taking ACE inhibitors. The ACE inhibitor works on her blood pressure on a more day-to-day, non-emergent basis. It works through her renal system. And so here's the quick and dirty on this, just so you have some background. Your kidneys secrete something called angiotensin 1. Angiotensin 1 does not one thing to blood pressure. The problem is that angiotensin 1 doesn't stick around very long. It becomes angiotensin 2. Angiotensin 2 is a very potent vasoconstrictor, so that would be raising blood pressure. So the way angiotensin 1 becomes angiotensin 2 is it gets converted by an enzyme called the angiotensin converting enzyme, ACE. If we could give this patient something that would inhibit the production and function of that ACE, of that enzyme, then that would be an ACE inhibitor, and that would then prevent angiotensin 1 from turning into angiotensin 2, and that's how she controls her blood pressure. ACE inhibitors end in pril. Lisinopril is very common. Many of your patients take it. Very few of them have angioedema. You'll run into angioedema a few times in your career, and statistically, it's not uncommon at all. It's pretty frequent that those folks are taking an ACE inhibitor. So what do you do for this patient? Well, it's scary, it's anxiety producing, but it's probably self-limiting, and there's no anaphylaxis component to this. So hold off on the epi. Remember, this person has blood pressure issues anyway, high blood pressure anyway. So we don't need to be firing up epi on somebody who's already got hypertension as a concern. And you transport them. Scenario 3 is a 66-year-old female, sudden swelling of the lips and tongue, just like before. But now this one has hives, mild itching, no wheezing, some trouble swallowing, has throat tightness, is anxious, Patient looks very much like the one you just had, only now there's an anaphylaxis component in addition to the angioedema. No known allergies, takes captopril, so that's an ACE inhibitor, hydrochlorothiazide and aspirin like we talked before, but this one also takes metoprolol, which because it ends in OLOL, you know is a beta blocker. So now you've got a patient who needs some epi, but has a bunch of beta blockade going on, and this might very well be the patient who medical control or maybe even standing orders within protocol allows you to reverse that beta blockade with glucagon. I would get on the phone. I would get on the road, then I would get on the phone. And here's what I've got. What do you think I should do? It's a judgment call. Do we want to turn around all this beta blockade that's doing good things in order for our epi to have some benefit, or can we get by with just Benadryl and wait this out and hope that the reaction kind of stops on its own and Benadryl takes care of the side effects? It's a judgment call. I don't think there'd be anything wrong with if this patient looks sick and is hypotensive, altered level, if they look unstable to you, then fire up some epi, reverse it with the glucagon, and move on. So scenario 1, scenario 2, scenario 3 lets you kind of practice and manipulate this stuff in your brain and work through that flow chart in real time.